Morning everybody. Today, as ma'am said, I will be presenting the same case. Coming to the case presentation, the patient named Vijay was 46-year male, presented in OPD with complaints of pain in lower back since 3 years, radiation of pain to bilateral lower limbs since 6 months, and difficulty in walking since 4 months. The pain in lower back was started with mild pain, but eventually it increased over years. Similarly, radiation of pain also was not there initially, but eventually radiation of pain also occurred. Then eventually he landed up in difficulty in walking. When he was presented to OPD, he was able to do only daily activities and self-care activities. So he was also a patient of hypertension, but he was not on regular medication. He was irregular in his treatment. He was also known case of obstructive sleep apnea. Excuse me. With stop bank score of 5. What is stop bank score? We use stop bank score especially in the obese patient to stratify whether obese patient is high risk or not. It includes snoring, tiredness, observed apnea, high blood pressure, BMI more than 35, age more than 50 years, neck circumference more than 40 cm, and gender male. In this particular case, stop bank score was 5. He was a snorer. He also observed apnea, then had high blood pressure, and neck BMI was 35, more than 35, and he was male, and neck circumference was more than 40. So patient also used to take CPAP at night at home using portable CPAP machine. Before he getting operated, he was admitted in pulmonary department, and sleep study was done. So with that sleep study, they prescribed him CPAP at night in home. So coming to the examinations, as I already said, patient was general examinations. Patient was conscious, oriented to time, place and person. Pulse rate was 74 minutes, respiratory 22 per minute. Blood pressure was 127/84. His weight was 108 kg and height was 170 cm. So his BMI was 37.4. So he came in the class of obesity class 2, that is 35 to 39.9. On examinations, his motor examination right and left limbs, bulk was normal, tone was increased, showing upper motor neuron disorder. Then power was functional, reflexes were present, and he also developed hyposthesia 60% below T8 and 10% below L4 L5 on right leg. He was investigated preoperatively. His hemoglobin was 13.9, TLC was 8000, platelet was normal only. His KFT shows creat of 1.2 and urea 45, sodium 141 and potassium 3.6. INR was 1.07 and serum bilirubin was also 0.76. Because he was obese and was going to go under major surgery, 2D echo was advised. It shows ejection fraction of 60%, and there was no motion wall abnormality or RV and RA were normal in this patient. With this MRI spine was done. There were multiple intervertebral disc desiccation with bulging in cervical or thoracic and lumbar levels, with ligamentum flavum hypertrophy compressing the thecal sac anteroposteriorly. So diagnosis was done extradural compression of myelopathy of cervical and dorsal spine due to ossification of posterior longitudinal ligament and ossification of ligamentum flavum. This particular CT image shows the problem in this patient. As we see, there was ossification of OP. Okay. This image shows the ossification in this patient. This again, this image shows the spinal cord was compressed at many levels from cervical to dorsal level. So because of which he developed these signs and symptoms. Because he was on CPAP, an obese patient, we took his pre-op ABG, which shows the pH of 7.43, PCO2 of 36.7, and PO2 was 93.9. Bicarbonate is normal. So patient was taken inside the OT. Standard ASA monitors were attached like ECG, pulse oximeter, non-invasive blood pressure, which shows following readings, and RAM position was made. So what is RAM position? In obese patient, because they are difficult to intubate, we do the RAM position so that the mandibular the same plane, so in same line, so that we can intubate that patient without any difficulty. So induction was done with fentanyl, propofol and vecuronium. Intubation was done with 8 mm flexometallic endotracheal tube using Macintosh blade, 4 number blade, and laryngoscopy showed CL grade 2A in RAM position. So why we used flexometallic tube? Because patient was planned to be operated in prone position. So in prone position there are chances of obstruction of PVC tube. So we inserted flexometallic tube so that compression should not occur. And Macintosh blade was used to because it was anticipated difficult intubation. 2 wide bore IV cannulas were secured, and arterial line, because it was expected to be long duration surgery and blood loss. We inserted arterial line with 20 G cannula in left radial artery for bed to bed monitoring of blood pressure. From spine surgery side, neuromonitoring was planned. These are motor evok potential, which are used to see the activity of the respective muscles when particular area is stimulated. And these monitors are attached when patient was kept in the prone position. Then neuromonitoring leads were attached and patient was prone. We have Allen's table in our institute. So because neuromonitoring was planned, muscle relaxant should be avoided in this patient. So we take patient in the TIVA, that is total intravenous anesthesia, with propofol, fentanyl and dexmed was chosen as anesthesia modality so that neuromonitoring could be done. The anesthesia, as already I said, TIVA is maintained with propofol, fentanyl, dexmed, and O2 and air was used for to ventilate the patient. The procedure went for 10 hours and total blood loss was around 1200 ml. Urine output in this patient was 150 ml. Urine output was stopped 3 hours before the end of procedure and did not improve despite we gave intraoperative Lasix 20 mg IV. So why urine was stopped? There can be multiple causes like acidosis or hypovolemia, or patient was already in the prone position. So it is observed that there is decreased perfusion of the kidneys in the prone position. So total in total procedure 5 liters of crystalloids were given and 2 units of PRBC were transfused. The blood pressure and heart rate were stable throughout the procedure. Neuromonitoring signal were adequate throughout. Intraoperative ABG done 6 hours post induction in view of reduced urine output, and it shows pH of 7.38, hemoglobin of 7.3, PCO2 was 35.1 and PO2 was 166 with 50% FiO2. Then sodium was 149 and lactate was 1. Bicarbonate 20.5 and potassium was 2.7. Once the procedure was over, the same patient was planned to send to the ICU because he was already obese and expected time of operation was long. So we asked for ICU bed in this patient. So we were also expecting airway edema in this patient because patient was in prone position, and also he has a history of obstructive sleep apnea with use of CPAP in night. So we were planning to send the patient in the ICU without extubation to do the overnight ventilation. Then patient was made supine after the end of procedure. Planned for bougie guided endotracheal tube exchange from flexometallic to PVC tube for elective ventilation. For elective ventilation, we don't use flexometallic tube. We always change with PVC tube. Bougie was used because it was already a case of difficult intubation and obese patient. So bougie guided tube exchange was done. Tube was exchanged within 1 minute. Bilateral air entry was confirmed by auscultation, and entire CO2 trace and patient was put back on the ventilator inside OT. 5 minutes later, the patient suddenly developed non-specific arrhythmias, leading to sudden bradycardia and hypotension, and then asystole. Immediately CPCR was started. The return of spontaneous circulation was achieved after 2 cycles of CPCR. Then because patient crashed and needed vasopressors, and for further management central line was secured and patient was started on adrenaline infusion. We thought patient might be landed in the cardiac arrest due to one cause like hyperkalemia. We also gave him the glucose insulin infusion, considering the cardiac arrest maybe due to hyperkalemia only. So cardiology consultation was done to rule out the myocardial infarction. Intraoperatively, SR of cardiology came. He did the echo. He found the normal RA-RV intraoperatively. There was no thrombus or clot. IVC was collapsible. There was hypercontractile left heart, and there is no signs of pulmonary embolism on echo. So patient was eventually shifted to ICU. ABG was done in the ICU, shown following readings. pH was 6.86, hemoglobin was 12.
This was not ICU,
OT only, okay. POT showed 85.4 mmHg PCO2, and PO2 was 124. So lactate were 9.6 and bicarbonate were 9.7. So as we see, PCO2 was rising despite we ventilated patient on ventilator with enough tidal volume and wind ventilation. PCO2 was rising. Then oxygen saturation and blood pressure gradually picked up, but this was inside ICU. Oxygen saturation, blood pressure was picked up, but end-tidal CO2 was coming low. Trace was coming lower side, approximately 18 to 24 mmHg. So we did the ABG again, which shows PCO2 and end-tidal CO2 gradient of 90 mmHg. Means the arterial carbon dioxide level was around 110 to 120, and end-tidal CO2 was like 18 to 24. So gradient was very high, that is 90 to 90 mmHg around. Then we thought that there is a possibility of pulmonary embolism. Repeat focus, that is focused cardiac ultrasound was performed by ICU team. At that time, we observed dilatation of RA-RV, and there was paradoxal motion of the septum because of enlargement of the right ventricle. Then in same night, the procedure was ended around 7:30 to 8 and was shifted to ICU, and CTPA was planned at midnight. So CTPA report shows the non-enhancing filling defects seen in the main pulmonary artery, that is sidal embolism, and extended into right and left pulmonary artery and their segmental branches. This is a echo of a person of massive pulmonary embolism, in which it shows the enlarged right ventricle, and left ventricle is smaller in size, and there is paradoxical movement of the interventricular septum. And this image on CTPA shows the saddle embolism in the pulmonary artery. Immediately injection heparin 5000 international unit were given. Embolectomy was planned, whether to do pharmacological medical embolectomy or mechanical embolectomy was discussed with the surgeon. They advised not to give TPA, that's alteplase. So mechanical embolectomy was carried out next day in the interventional radiology department, and patient's urine output gradually improved. Then patient after 1 to 2 next day, the patient was having spontaneous efforts and was kept in the patient support mode for the next day. Still GCS was poor, that is E1, VT, M1, and because GCS was not improving, and we were planning to ventilate patient for longer period, we planned tracheostomy, and it was done after 4 days. In view of non-improvement of GCS, MRI brain was done. MRI showed the multiple infarct in the bilateral occipital and cerebellar hemisphere. There were more infarcts on left side than right, and these infarcts likely were embolic infarcts. There was observed attenuation of caliber in the left vertebral artery, which was likely thrombosed, which may be the source of embolism in the cerebellar and occipital infarcts. There was high prevalence of vertebral artery hypoplasia. There is high prevalence of vertebral artery hypoplasia in the normal population. It is normally seen, but it is not diagnosed because we don't do routinely imaging. The patient stayed in ICU for about 10 days, during which GCS improved to E4 tracheostoma state and M3. After 40 days, patient was discharged with status E4 tracheostomy in situ and M3. This image shows the cerebellar and occipital infarcts, and this image shows the left vertebral artery attenuation. Patient was discharged from the orthopedic ward. Again in around December, patient was readmitted under Department of Medicine in medical ICU in view of respiratory distress with altered metastasis. So in this case, because there was history, they did urgent CTPA. Saddle thrombus was again observed in the right and left pulmonary artery and segmental and subapical branches. Lung parenchyma also shown the infective changes. The intervention radiology opinion was taken, and catheter directed thrombosis was done using alteplase. There was significant improvement in the pulmonary blood flow. MRI brain shows the age inappropriate brain atrophy, and CSF analysis was done which showed high protein and low sugar level. Because there was infective changes in the lung, community acquired pneumonia was suspected. So adequate antibiotics were given, and after stabilization patient was shifted to the ward. Eventually patient was discharged on 31st of December 2022 with DVT prophylaxis with tablet rivaroxaban, and discharged on with Foley's catheter, rise tube and tracheostomy in situ. Current position of the patient. Patient is E4, tracheostomy in situ and M6 with power 2/5 in all 4 limbs. The next plan for the same patient is tracheostomy tube decannulation in the next visit. This was the case. Then we did some paper search. We found that surgical duration and risk of venous thromboembolism was increased. It was a retrospective cohort of around 1.4 million patients. It was done by American College of Surgeons and National Surgical Quality Improvement Program from 2005 to 2011. They found that the overall venous thromboembolism rate was 0.96%. The rate of 0.33% of DVT and pulmonary embolism. The association between surgical duration and venous thromboembolism increased with the stepwise fashion, and patients undergoing longer procedures experienced 1.2-fold increase in the odds of developing venous thromboembolism. The robustness of these results was substantiated with several sensitivity analyses obtained to minimize the effect of outline concurrent complications and procedure differences. So conclusion was, among patients undergoing surgery, and increase in surgical duration directly associated with the increase in the risk of the venous thromboembolism. Coming to the association between obesity and venous thromboembolism, the case control study was done, which showed the obesity was associated with 6.2-fold increase in the venous thromboembolism, and it is highest in the patient aged more than 50 years. And cases included in this study was class 2 and 3 obesity. Our patient was class 2. Another required risk factor for the risk of venous thromboembolism. Coming to the OSA and thrombosis, the obstructive sleep apnea causes blood hypercoagulability, venous stasis, and endothelial dysfunction, which other common risk factors are obesity, age, and prolonged inactivity. As we know, Worcester says that venous thromboembolism occurs due to the three reasons only. So, in obese patient who are obstructive sleep apneic, we can see venous thromboembolism, DVTs, or pulmonary embolism. Coming to the risk factors for venous thromboembolism following spinal surgery, the meta-analysis was done, which was done around 30 lakh people, like around more than 3 million population. So risk factors were analyzed in this meta-analysis, which shows risk factors like Asian ethnicity, increased age, female sex, diabetes, known case of chronic kidney disease, then non-ambulatory perioperative status, then D-dimer level, duration of operation, spine fusion, and the blood transfusion. In same study, they observed no risk factor with BMI and obesity, then hypertension, coronary artery disease, then intraoperative blood loss, and surgical site. So, in this study, rather they said that obesity is not associated, but in many studies it is found that obesity is associated with increased venous thromboembolism. Then there was also a study, a review of 405 patients were done. It was cohort analysis, which shows the in cervical spine surgeries there is a risk of thromboembolism disease. We went through research article. We found two articles in which patient was in prone position, and once we changed the position from prone to supine, they observed the severe pulmonary embolism as we observed. One study was in Japan. In this surgery, patient was prone for around 15 hours. So when they did the supine position, patient underwent the severe pulmonary embolism. Same in the case report observed by Hong and all, observed the patient position change lead to the pulmonary thromboembolism. This article they mentioned that patient was on Jackson table. So in Jackson table, what happens? The lower limb like knee and thigh are below the level of the heart. So there are high chances that venous stasis can occur for a prolonged period due to the position and may have resulted in the thromboembolism. In this particular case, they did the thrombectomy with the altiplase, but they observed lot of bleeding, and they needed to give blood and blood products in their patient. So in our patient, what went wrong, because of which he developed severe pulmonary embolism. The causes in the preoperative, like it was a major surgery, and he had decreased mobility due to hospitalization, obesity, and the current problem with the compression at multiple level. Intraoperative period were prolonged. Patient was in prone position. Intraoperatively, 2 points of PRBC were given and tranexamic acid was used. So to avoid this pulmonary embolism, what could have been done? First, we didn't have the preoperative lipid profile. We also not rule out a patient for homocysteine protein CS and because of recurrent venous thromboembolism. But preoperatively there was no incidence of venous thrombosis or pulmonary embolism in this patient. So it was not correct to do routinely these investigations. But there also consensus for high risk patient for preoperative thromboprophylaxis should be there, and consideration of IVC placement can be considered in this patient because of repeated pulmonary embolism. So what is preoperative thromboprophylaxis in patient with multiple risk factors? Preoperative pharmacological thromboprophylaxis decreases the odds of venous thromboembolism in perioperative period for major surgery by approximately 40%. So for prophylaxis, we can use unfractionated heparin and enoxaparin. Initial treatment we can start, and for long term it is better to give oral treatment, because subcute heparin is tedious for patient to take at home. Then we could have used mechanical devices for thromboprophylaxis intraoperatively. The mechanical and pharmacological method of venous thromboembolism prophylaxis are both effective, and when used in combination have synergistic effect. For this, there was concurrent review which showed when patient was only used mechanical and when there was pharmacological method of prophylaxis was added, there was definitely reduced level of embolism in these patients. And when they did the reverse, like when patient is on pharmacological prophylaxis, when they added the mechanical prophylaxis with the IPC pump, they showed the decreased incidence of venous thromboembolism. And when they also observed that when pharmacological method of prophylaxis was used, there was increased chances of bleeding. And we also can consider the minimization of the duration of surgery. Among patients undergoing surgery, an increase in surgical duration was directly associated with increase in the risk of venous thromboembolism. This finding may help to inform preoperative and postoperative decision making related to the surgery. But how we can reduce the duration of surgery? Because in this patient, very intensive surgery, very planned, because either we can plan in staged manner, but it showed that stage surgery has more risk of thromboembolism rather than going for single surgery for longer duration. So these became very dicey. These were references I used to make a PPT. Thank you.